So good evening everyone, and as the RIC mentioned that it's all a learning for all of us how to be using more and more of Octa in our clinics. So Octa of course helps in both qualitative and quantitative assessment of diabetic retinopathy, and all the features that we have been appreciating on a fundus fluorescein angiography are quite possible to now recognize on an Octa. The various OCTA metrics also are being used, such as vessel density, Far's area, area of non-perfusion, which all help us to monitor the progression as well as a response to diabetic retinopathy management. As far as microaneurysms are concerned, the sensitivity of Octa is of course low in comparison to a fundus fluorescein angiography, and this being because of a slower flow speed in microaneurysms, which is beyond the detection threshold of an Octa. However, the advantage of using an Octa in recognizing microaneurysms is that we are able to exactly locate the level and also see the various morphological patterns which earlier we were not able to recognize on a fundus fluorescein angiography. And it is said that these microaneurysms in DR are found to be more in the deep capillary plexus in comparison to the superficial. We can also image IRMA, and it is visualized better on NFAS images, and they appear as dilated or looping vessels which are found near the areas of capillary non-perfusion. So these are one of my patients where you see the fundus fluorescein angiography, and you are suspecting an IRMA somewhere over here, and when you see it on an Octa, you are able to again localize the IRMA quite well. The caliber of these loops is noticeably greater than that of the surrounding normal capillaries, and that's how you'll end up recognizing them. Now, this is interesting how to image neovascularization using Octa. You have the disruption of the ILM, and which helps you to differentiate IRMA from NVE. You have certain advantages of Octa over FFA. Very subtle NVEs can be detected, which probably would be indistinguishable from microaneurysms on an FFA. And also the precise measurement and monitoring the size and the regression of NVE is more possible on an Octa in comparison to an FFA. The disadvantage is when you have very elevated NVEs much above the ILM, probably they may not be picked up on using an Octa. So I would just like to thank the RIC for providing me a few of these beautiful images. And what you see over here on an FFA, you have these leaking NVEs, you have capillary non-perfusion areas, and you are able to appreciate them quite well when you are using an Octa. You see the NVEs over here, and also the capillary non-perfusion area, which are quite the same as you appreciate on a fundus fluorescein angiography. You have this extensive neovascular front sitting over the disc, and you have extensive capillary non-perfusion, which again is quite well appreciated on an Octa. So Octa helps in also monitoring the treatment response of diabetic retinopathy. You can actually see the regression of the neovascularization, though there may not be much change in the density of superficial or the deep capillary plexus. The choriocapillaris I won't touch upon because Dr. Munna explained it beautifully yesterday. And this is one of the patients you see again on a fundus fluorescein angiography. You have an extensive leaking NVE. You have this active NVE again, which we are able to see on Octa. However, post-laser treatment, you see that there is a marked decrease in the leakage, and also you are able to appreciate the regression of the NVE on, again, doing a repeat Octa. On a higher magnification, this is pre-laser, this is post-laser, you see the regression. And you see this is quite elevated above the ILM, and this has regressed after the laser treatment. And this again is showing that you are having the flow signals present in the ILM when the NVE was active, and the flow signals have disappeared. This is again on a higher magnification, you are able to see it better. Extensive flow signal above the ILM showing it's an active NVE, and that has completely gone, and there is a regression of the NVE. This again is a fibrovascular front over the disc before the treatment, and this is again you see the regression after the laser treatment has been done. This again you can see the response to treatment. This is pre-vitrectomy, and this is again post-vitrectomy. You see there's a marked regression again of the neovascular front over the disc, and there is also an extensive capillary non-perfusion which is present all along. There is a possibility of doing a quantitative assessment of the foveal avascular zone using an Octa, and both of these are found to be significantly greater in eyes with diabetic retinopathy compared to normal and diabetics with no DR. The contour of the FAS on FFA correlates pretty much well with the Octa, and it can be used as a screening tool when we are wanting to rule out a macular ischemia. So here we have an evidence which is you having enlargement of the foveal avascular zone on superficial capillary plexus and also on the deep capillary plexus. And I find this tool extremely useful when I'm dealing with a patient who's being planned for a vitreoretinal surgery, not able to undergo an FFA for various reasons like a renal problem. I find this tool very useful, which helps me to prognosticate my case. You have the enlargement again of the foveal avascular zone as the disease is progressing. You see there is a much more enlargement and there is a capillary dropout surrounding this area when the disease has progressed to a severe stage. However, it is said that the parafoveal DCP vessel density is said to be having a more robust association when we are wanting to stage NPDR as per the ETDRS classification. We've been talking about drill, which again is very much well appreciated. You have a fundus fluorescein angiography. You see this extensive CNP area appreciated as drill on an OCT-B. And again on an Octa, you can correlate. There is an extensive flow void area which is corresponding to the area of the drill that you see. This is another advantage of using an Octa, where you can recognize a subclinical diabetic retinopathy. And this is again a non-invasive technique, a three-dimensional technique which offers advantage over an FFA. The changes that we may appreciate when we are diagnosing a subclinical diabetic retinopathy are decrease in the deep plexus vessel density, enlargement of the FAS, a decrease in the parafoveal vessel density in both superficial and deep vascular layers, and also the impairment of the choriocapillaris flow. So this was one of the patients. On clinical examination, we said there was no evidence of diabetic retinopathy, but when we did an Octa, you could see these peripheral areas of capillary dropout, and that means that the diabetic retinopathy was setting in, which was apparently missed out on a clinical examination. There are changes in the choriocapillaris which do happen, and we know that there is an involvement and it plays a role in the pathogenesis of diabetic retinopathy. You can have non-perfusion areas in choriocapillaris, and they have been very much detected in DR. And these areas again increase with more severe stages of diabetic retinopathy. So you have an earlier onset of a DR where you see the microaneurysms, you see the capillary non-perfusion areas, you see an enlargement of the FAS with a notch, and as the disease is progressing, the choriocapillaris is also showing the flow void areas. As far as imaging in diabetic macular edema is concerned, the fluid may interfere with imaging and segmentation. The cystic spaces are sometimes hard to distinguish on a fundus fluorescein angiography, and this possibly could be because of the surrounding leakage. Octa cystoid spaces are oblong-shaped total void areas with smooth margins, and whenever you have DME, you find that the microaneurysms are more in the deep capillary plexus. So you see these are well appreciated. On an FFA, they are quite covered with the surrounding leakage, but on an Octa, you have these oblong spaces which are quite well appreciated, and again on an OCT-B, they are well seen. So I would just conclude by saying that Octa offers the advantage over FFA in being non-invasive, much safer in patients with dye allergies and renal problems. A quantitative assessment and depth of lesions is far more possible to assess with Octa in comparison to an FFA. A subclinical detection of DR is possible. However, Octa and FFA both do have their own advantages and limitations, but they do complement each other. Thank you so much.